I'm Dr. Barbara Schwartzberg. It's very much a pleasure to be here today to discuss with you a topic that I'm really passionate about, intraoperative radiation therapy. Quickly, I have two disclosures to make. I am a investigator for Zoft, who makes the IORT equipment used here, a division of ICAD, and also for the laser company that was discussed, Novian Health. So today we're going to talk about intraoperative radiation therapy. Now, this is not the radiation therapy that you may be thinking about. This is not cobalt. This is not taking an anesthetized patient down to the radiation oncology suite. This is not working in a bunkered down lead room in the basement of a building, because it's the only place that will support that type of equipment. This is actually radiation therapy made from electricity called electronic brachytherapy, and basically it has really revolutionized what we can do with radiation therapy, bringing it into the operating room. It basically uses standard equipment. First, we start by doing a standard lumpectomy, placing a balloon into the cavity once we've cleared the margins in the sentinel lymph node. And then this balloon is docked to a very nimble little accent controller, which delivers the radiation. Basically, this is plugged into a household electric socket. It runs electricity through a mini X-ray source over a tungsten crystal, and it converts it to very, what I call bright, shallow radiation, 50 kV photon sources, and it delivers 5 to 7 grays at the surface of the balloon, very shallow penetration of about 1 centimeter, and then quickly dissipates it. So it's very good to be done inside the operating room. Now, were I a fancy physicist or a fancy radiation oncologist, I could talk to you about alpha beta waves and the ratios. That's a little bit beyond the surgeon. However, suffice it to say that the alpha beta ratio that this type of radiation produces is perfect for breast cancer. Breast cancer cells are very susceptible to this type of radiation, and it's been shown to be very effective. So, as was alluded to, really the grandfather of all the trials using electronic brachytherapy is the Target A trial, which was championed in the UK by Dr. Vaida. Basically, it used the same technique I've been talking about with electronic brachytherapy using photons, delivering a single dose of 20 grays of radiation to the lumpectomy cavity for cure. The trial started in March 2000, ended in June 2012. Enrolled a total of 3,451 patients. There were 33 sites in 11 countries. Patients were required to be at least 45 years of age. The tumors could not be any larger than 3.5 centimeters. It was a risk-adjusted study. So just dropping down to the positive and negative lymph nodes for a second, basically patients went into the study with the intent to do IORT. If, once it was completed and the final pathology was obtained, we found that the patient had a positive sentinel lymph nodes or had a high-risk pathology, the patient could be risk-adjusted and go on to receive whole breast radiation, even having already gotten IORT. So in these cases, the IORT was used as a boost. And actually in this study, about 15% of patients did go on to get whole breast radiation. Now, a second issue, I talked about it being risk-adjusted. The trial did change through the course of the trial over the 12 years. When it first started in 2000, the inclusion criteria were that the patient had to have their radiation during the surgery, during the lumpectomy, once the initial, at least, gross pathology intraoperatively was cleared. The margins were cleared. Then, for some reason, the investigators in March 2004 decided to change the criteria. Patients no longer had to have the radiation during the study. We could get the final pathology report and then make a determination whether or not the patient was suitable for intraoperative radiation therapy. If those patients were, they could be taken back to the operating room and have their intraoperative radiation at a later date. So this started in 2004. Actually, about a third of the patients did undergo post-pathology radiation, mostly in Australia. The average time gap was about 30 days. And when the trial ended, actually 30% of the patients, or 1,141 patients, ended up having post-pathology treatment. So put a pin on that thought. I'm going to come back to it. The mean follow-up actually was 29 months as far as the last report was done. And the reports are a little confusing. The statistics are a little confusing. This has been one criticism of this study. The reports cite a follow-up of 29 months, but in the report are actually Kaplan-Meier projections looking at the ipsilateral recurrence rate based on the results they had at 29 months. And they reported that with the IORT group, there was a 3.3% reoccurrence rate versus a 1.3% whole breast radiation therapy reoccurrence rate in that group. Now, this was a non-inferiority study. The criteria set at the beginning of the trial and powered for this had a non-inferiority differential of 2.5%. So based on these projections, the trial did meet those criteria. Now remember I talked about the pre and post pathology. Let's drill down on that a little bit. When the investigators broke this study, these subjects, into two groups, they realized that there was actually a really big difference in the reoccurrence rates between the pre-pathology group, which had their treatment during the surgery, and the post-pathology group, which basically had their intraoperative radiation therapy 1 month after the surgery. In the pre-pathology group, those patients that had IORT had a 2.1% reoccurrence rate versus the whole breast radiation group, where the reoccurrence rate was 1.1%. So really only a 1% difference, meeting the non-inferiority risk criteria. Very different with the post-pathology group. The reoccurrence rate with that group, with IORT, was 5.4%, significantly different, versus the 1.7% with the whole breast radiation therapy. So there's really been two take-home messages, for me at least, and I think for everyone, in regards to this trial. A, it was very well done. It has its faults, but it was very well done. Basically, patients, if undergoing intraoperative radiation therapy using electronic brachytherapy, really should have it done during the surgery. That's when it really works. The other thing is that patients can be risk adjusted. If you do IORT on a patient and then find out on the final pathology that they have micrometastases in the sentinel lymph nodes, the 20 grays that's used with the electronic brachytherapy is acceptable. You can use it as a boost. You can do whole breast radiation after it. You can even do hypofractionation after it, and the breast will tolerate that without a problem. So this is a very flexible type of treatment. I really say that only, and not to be confusing, for those of you who know about Mobitron, which is electron brachytherapy using the big equipment. In those patients, if IORT is used, that type of radiation is too powerful to be used as a boost. So you can't have a patient with electron, Mobitron brachytherapy, then go on and have whole breast radiation layering over it. So this is one of the great many advantages to this type of 50 kV electronic brachytherapy. Now, we talked about the Target trial. To be frank, that actually uses the Zeiss intrabeam technology. The two types of equipment are a little bit different than what we're talking about here tonight with the Zoft technology, but they both use electricity run over with the Zoft. It's a tungsten crystal. With the intrabeam, it's a gold crystal to produce the 50 kV radiation. Zoft has the other big trial going on. This is a one-armed prospective study. It started in 2010. At the time that Dr. Zaid presented this at ASTRO in 2017, we enrolled 1,056 patients. Now, a year later, this has been closed to accrual with 1,200 patients. At least at the time of this presentation at ASTRO, that he had an average of 1.5 years follow-up. There were no breast cancer-related deaths, and there were 6 ipsilateral reoccurrences, or less than 3%. This also is a multi-institutional study. It includes patients not only in the United States, 27 hospitals in the US, also one in Australia and one in Portugal. So, where are we seeing IORT? IORT is really commonplace in many parts of the world. It's been available for 20 years. The target trial encompassed actually 11 countries: the United Kingdom, Germany, Australia, Italy, the United States, Denmark, Poland, Canada, Switzerland, Norway. The ZOFT expert trial, which I just talked about, was in the United States, Australia, Portugal. ZOFT has many international sites: the United States, the United Kingdom, Spain, Portugal, Taiwan, Switzerland, Russia, Bulgaria, India, and they're about to start a big program in China. And it's now considered the standard of care in the United Kingdom and in Germany and in Australia. So this is what's happening. So where am I in all this? I'm in Denver, Colorado. I am in a nice private practice hospital. I've been there for 35 years. In fact, I've never even moved off of the 7th floor of my office building. But it's been the private practice treatment teaching arm of the University of Colorado. We have students, we have residents, and I've really been allowed kind of a full run with my CEO of doing a lot of research over the years. I've been very lucky. So we started doing IRT in 2011. I first started with a very quick 50 single institution patient pilot trial just to kind of see how this worked and to gather some nuts and bolts information. Over the years, our inclusion criteria have evolved. Now, this is my current inclusion criteria. It's really quite broad. Patients need to be at least 40 years of age, which is quite young. Single lesion, it can be no larger than 3 centimeters. It can be either infiltrating ductal carcinoma. We've now added infiltrating lobular carcinoma. We've been doing ductal carcinoma in situ since 2012. We allow all molecular subtypes. So we're not just doing estrogen receptor positive patients, we're doing triple negatives, and we're doing some HER2 new positive patients, although more recently with the advent of Perjeta and the initial requirements that this should be done as a neoadjuvant setting, those patients are going into that venue and aren't getting IORT. But we do have some HER2 new positive patients that have gotten IORT. And then obviously there's some intraoperative inclusion criteria that patients need to meet. The sentinel lymph node needs to be cancer-free. If we find out afterwards it's positive, they get whole breast radiation as an adjunct treatment, and they do have to have negative margins. Now we'd like to see a 2 millimeter margin. We will take a 1 margin if it really looks clean. If we do have a positive margin, we're allowed, these are our rules, to go back and take 1 margin re-excision without subjecting the patient to more radiation. If we can capture the margin on that second go-around, we don't deliver any more radiation. That's basically what we've been working with. The exclusion criteria are a little broader. Patients cannot have multifocal disease. We do not want lymphovascular invasion. No patients can have a history of a previous breast cancer and or radiation. No neoadjuvant chemotherapy or endocrine therapy. No patient can be pregnant or lactating. And then there's some more rare exclusion criteria: scleroderma, active lupus, ipsilateral pacemaker, and they cannot be BRCA gene positive. Now, we do a standard Denver workup. Obviously, we start with a screening mammogram. If there's anything suspicious, the patient will get magnification compression views. We rely very heavily on ultrasound. Now, Denver is the home of Drs. Steve Harms and Dr. Steve Parker. I'm sure those names ring a bell to some people. It's a very MRI-driven location because of those people, those radiologists. But in reality, getting an MRI is not a mandatory requirement for this case, and there certainly are patients who don't get MRIs. It simply happens to be part of the Denver culture, and but it certainly can be done without. So, what is our treatment program? Our hospital is geared to finding IORT patients. All the doctors, the medical and doctors, the primary cares, the breast radiologists look for IORT patients because they know how well this works and how much patients like it. But really, the surgeons are the gatekeepers. The patients start with the surgeons, and the surgeons are the ones that really talk to the patients, present the options, maintain their care, do their surgery, and then arrange for the rest of the team to come together. So when you do IORT, it's kind of like a play. You need a director, you need actors, you need a makeup crew, and then everyone comes together for the 2 hours of the procedure to do the case. So patients need to meet these people up front, people need to know their role. So certainly the radiation oncologist and or physicist needs to meet with the patient and kind of agree that the patient is a IORT patient candidate. Certainly the medical oncologists are involved also. Obviously they're looking more at chemotherapy or endocrine therapy, but it's a collaborative effort. We're all good friends. We keep everyone on board. We coordinate the surgical schedule. Everyone knows these cases need to be done together. Now, we're to the volume now that every Monday morning is IORT day. That's when we schedule the IORT cases. The surgeons are free, the radiation endophysicist is free, and that's when we come together. And sometimes we even flip-flop rooms, kind of passing the equipment back and forth, and we can do 4 patients in the morning. It'd be nice if you guys got up to that volume. It really works. It's so efficient. So many people get treated. But in the beginning, it basically just requires probably a conference call between the various departments, making sure that the appropriate people are free. Once we have the patient in the operating room, we start with the lumpectomy. And usually at that point, a call is made to the radiation oncologist and physicist that we started the case. Once the sentinel lymph node's out, we call the radiation oncologist. The node's out. If it's negative, they get a call, the node's negative, get over here. By the time they arrive, the radiation, the IORT balloon is in place. We all review the plan, agree that the patient is an appropriate candidate. The IORT is delivered in 8 to 12 minutes. The balloon's removed, the wound is washed out, local anesthesia is injected, and the patient goes to the recovery room. Then obviously, if the patient's a candidate for chemotherapy, that's administered, or endocrine therapy if indicated. I must say our hospital is so heavily IORT bound and also Oncotype DX recurrence score bound that we do very little neoadjuvant chemotherapy unless it's a HER2 positive patient, because we really feel that many patients, especially now with the new TAILOR-X results, don't need chemotherapy. And so with well-done surgery, the radiation, it can be done after those 2 treatments. I've only had a few patients where we've had radiation recall when they've had their chemotherapy post-op. Just to recap this in pictures, here we are in the operating room. We do use liposartan blue, and this is still with the needle local, although sometimes we'll use a Savvy Scout localizing device. The sentinel lymph node is removed, sent to pathology. The lumpectomy is done in a standard fashion. We usually try to come kind of down onto the breast location to make sure we get those good margins for when we move on to the IORT and wrap that balloon with surrounding tissue. Once we've cleared the margins and the lymph nodes, we go ahead and place a shield against the chest wall. This is usually a 6 centimeter stainless steel shield. It protects the heart, lungs, ribs. If possible, I actually tuck it behind the pectoralis major muscle, either splitting the muscle or lifting it on the lateral edge so that that posterior wall is really given the appropriate treatment. There's nothing left there untreated. On the right, you can see a picture of the shield in place. It's obviously removed after the treatment, before the wound is closed. We then check a balloon for integrity, put it into the wound, and the balloons come in different sizes. You can fill them to different volumes. All that is calculated into the treatment plan by the physicist. And then the overlying skin is reapproximated with temporary retention sutures, and we then check the balloon with an intraoperative ultrasound, both to make sure that there's good tissue apposition to the balloon surface so we get good delivery of the radiation, and also to make sure that the skin is protected. Now, in our original studies, we required a 1 centimeter margin buffer between the surface of the skin and the balloon. In this case, I believe it's 1.38 centimeters. The results have been great. So we've actually now narrowed this margin to 7 millimeters with very good results. It really opens it up to more patients and an easier technique. I know Silverstein, Dr. Mel Silverstein, has relaxed that criteria to 8 millimeters. So I think the 1 centimeter, which actually initially was set quite arbitrarily, is now maybe even a little bit generous. Then the accent controller is brought into the room. Here's the radiation technologist, the radiation oncologist. You can see how small and nimble this is. I always describe it as kind of like a large carpet cleaner. It's about the size of it and about as nimble. It really rolls around. It's easy for someone small like me to move. And here, these are standard X-ray shields that we use. We protect the anesthesiologist and the radiation oncologist. We step into this semi-sterile room while we have delivery. Now, although on other cases you might have time for a cup of tea while this is delivered, the radiation here is only usually for me 8 to 9 minutes. I barely have time to sit down. And then I'm up, it's done, patient's done, they've had all their surgery, all their radiation, in the same time it would take to do a mastectomy, and yet they're able to keep their breast. And here we have the accent controller is set up. Nice thing about the Zoft, again, one of the many reasons I like it, you can come in from a lateral approach. I've even come in through the sentinel lymph node incision or an inframammary fold incision to place it precisely where the cancer is, and I know where the cancer is or was, to really get that targeted treatment. So our first 40 cases, just to give you some nuts and bolts information, we were just starting out. I was teaching the nurses, I was teaching the anesthesiologists, I was teaching the pathologists. So given that, still our average age was 64, average tumor size was 1.04 centimeters. We tend to have a well-screened population with small tumors. Average radiation time, I've got this in seconds, 512 seconds, about 8.5 minutes. And skin to skin, including all the radiation, I really took note on this. 1 hour and 47 minutes was my average. So really, you can get this done with all the radiation in less than 2 hours. And the average skin to balloon surface distance was 1.21 centimeters. Very efficient.